So congratulations on sticking through the asthma marathon. I just wanted to append a couple of my answers. One of your colleagues here actually works in an allergy clinic, and so she has more direct experience with the biologics than I do. And so for the question about biologics and pregnancy specifically, what she said was that if a patient is already on a biologic and then they get pregnant, they will continue the biologic like Xolair, mostly because of the risk of anaphylaxis. So if it's a patient who's already pregnant and then comes to you for Xolair therapy, in that situation, they would hold off until after the delivery because they really don't want to have to deal with the potential risk factor of anaphylaxis and needing to use the EpiPen. So that was the one major point. Thank you all for people who stayed behind, and we had a great discussion about questions. One of the other things that came out was one way to think about combination ICS and formoterol therapy and kind of where asthma therapy is leading is don't ever, 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 ever give your patients short-acting bronchodilator. Even for the mild people, please give them inhaled corticosteroid and rubber band it. Tell the patient to rubber band it together. So take that ICS inhaler, take that short-acting bronchodilator, put those two together, put a rubber band around it. So every time they need one, they use the other. That's a good way. Rubber band it in your own heads and rubber band it in your patient's head. So those were the two key points I wanted to bring out. So big deep breath. We just have COPD to go through, okay? So COPD updates in managing in primary care. This, I will say that the majority of the slide talk is similar. However, the GOLD group, analogous to GINA, they also did update their guidelines during COVID, and we'll go through that. I will emphasize what's different. So we're going to go through the same structure, go over the high-yield assessments of how you want to understand your COPD patients. We'll talk about the guidelines and pickle in the gold juices. And then we're going to talk about creating a comprehensive plan and managing these patients in your clinics. I have no disclosures. So in terms of nurse practitioners and PAs and the like, less than 10% of COPD patients are actually seen by me, a pulmonologist. 90% of these patients are all your privilege to deal with. So COPD is a public health problem. These stats, actually, the slide was before COVID, BC. I did not change it because the statistics pretty much are the same. COPD is the fourth leading cause of death in the world. It's the third leading cause by 2020, responsible for 6% of deaths in 2012, and 6% and 30 million patients in the U.S. 30 million people in the U.S. actually have COVID and COPD. And we know that the incidence of COPD is rising with age. More than half of our patients will be 75 years or older by 2030. Okay, so high-yield definition bolded, common, preventable, treatable, with persistent respiratory symptoms and airflow limitation that is due to airway and alveolar abnormalities. And it is caused by significant exposure to noxious particles or gases. So I don't have to belabor this. We talked about this in the talk and in the questions. My oak tree analogy is really awesome, if I do say so myself. Patients remember. All right, so the pictorial here is your lung parenchyma, the airways or the branches of the tree are the kind of scaffolding. They actually hold the lung tissue in a form of structure. And COPD, or airflow obstruction in the airway, is caused by a lack of that scaffolding being intact. So what you end up having is disrupted alveolar attachments. As the leaves start falling off, some parts of the airways or branches start sagging, right? So by analogous, when the airways lose their scaffolding by disrupted attachments around the lung tissue, those airways will tend to collapse. If the COPD airways are inflamed with mucus and other stuff and inflammation inside, then there's going to be a lot of sludge inside the airways, and the patients are going to have that chronic bronchitis presentation, chronic sputum production, okay? So this is basically that same cartoon in an actual histology. Here's your normal airway with you have a nice, wide open, clear airway with air in the middle. And here you have all the lung tissue nicely arranged. That lung tissue is the alveoli, right? So this is all your type 1 and your type 2 pneumocytes that make up those alveolar walls. This is a collapsed airway. It's lost some of its tethering. The leaves have come off, and the airways themselves are very thickened and narrowed. Thickened and narrow airway with a lot of inflammatory sludge, and your patient's waking up in the morning with a cough. If they smoke, they have a smoker's cough. Okay, this is what emphysema looks in an x-ray. Basically, you've got that barrel chest shape. You've got flattened diaphragms, a big heart, but a lot of dilated apices of the lungs. So this is emphysema on x-ray. This is emphysema on autopsy. I don't need to say anything there. Okay, causes of airflow obstruction. So here's a little cartoon from Google Image, which basically shows you all of the different noxious particles and gases people can be exposing themselves to by smoking cigarettes. I tell my patients, if cigarettes were good for you, if vaping was good for you, if inhaling marijuana was good for you, I would make my babies do it. I don't make my babies do it. I don't want you to do it. Okay? Smoking and secondhand smoking is basically the biggest cause of COPD, but there are other causes in the world. The wood smoke exposure is a big cause, occupational exposures. New data, emerging data, talks about how poor and compromised early lung development can predispose you to lung disease, including asthma, including COPD, even if you never smoked. Okay, and then of course, if you have alpha-1 antitrypsin deficiency, then basically you're going to have a lot of problems with your lung parenchyma, and therefore you will also develop emphysema, and that is a genetic cause of COPD. All right, this is a book I love. It's called The Cigarette Century. It was published a long time ago, but this book actually taught me that cigarettes were basically the worst invention ever, ever, ever. Cigarettes were first created, and then a market was developed. So the first cigarettes, the Native Americans used to smoke for medicinal purposes. They used the highly concentrated tobacco for religious ceremonies, et cetera, and they would smoke small quantities. And then somewhere down the road in the early 1800s, some dude figured out, well, why don't I make a cigarette making machine? I'm going to roll up the tobacco, I'm going to wrap it up in a piece of paper, and I'm going to roll it out. And it took a few trials, and by version 3 or 4.0, they diluted the tobacco plant down into something that was less irritable to your lung, and then they said, voila, here's the cigarette. And they manufactured a product without a market. It was like Steve Jobs in the garage, but bad, okay? And so that this first cigarette making machine produced 500 like in an hour, okay? And then after that, it was off to the races, a whole industry of advertising and marketing and science. People used to smoke in the hospitals because cigarettes were part of the culture. The reason I learned about this is my veterans tend to blame themselves for their smoking history. But I tell them, the government gave you rations. We used to put a penny or a nickel in a packet of cigarettes, and you would get money back for buying cigarettes. And we addicted your brain to nicotine when you were just a kid. Some of my patients started smoking when they were 3 years old. Okay? So I thought that was totally strange until I read this book. So if you like to read, if you're on the beach, pick up this book. Great book. So in terms of the pathogenesis of smoking, cigarette smoke or other kind of exposure will cause inflammation in the lung. That inflammation will eventually lead you to a COPD-type pathology of airflow obstruction. through various bad things that happen in your airways, oxidative stress and other proteinases that start to cause bad things. The green is good, so there's repair mechanisms, antioxidants, and other antiproteinases mechanisms. But at the end of the day, eventually with enough toxic smoke exposure, you're going to have some form of lung inflammation and chronic COPD pathology. Having said that, only 20% of smokers end up getting COPD. But 100%, or in America, at least nearly 100% of patients with COPD have smoked, okay? So not everybody who smokes will get COPD. But I will tell my patients, your lungs you spared, but remember that heart attack and that stroke you had and the peripheral vascular disease? That's the reason to stop smoking, okay? So smoking is not free if it doesn't affect your lungs. In my patients, nearly everybody who smokes, everybody who has COPD has smoked quite a bit. Okay, so this is a classic slide, 1970s, it's the Fletcher-Peto, which basically talks about how lung function declines. Nobody can give a COPD talk without showing you guys this slide. And this slide in the green is basically the physiology of your airways. So you're born, assuming you're born healthy, you get to peak airflow in your airways in your mid-20s. And then guess what? After that, time and age works against you. So after your mid-20s, aging is, you know what? Lung function declines over time. This isn't a non-smoker, okay? If you smoke, lung function declines more rapidly. You see that cliff? You're falling off that cliff. If you quit smoking, the data shows that the longer you remain smoke-free, you can never regain the function that you lost. The lung emphysema will never come back. The lung tissue won't come back. But as you age, your lung starts aging normally again. Your lungs kind of forget that you smoked if you remain smoke-free for about 10 years. So you can at least normalize your aging pattern again, okay? And then if you smoke, and then you have a lot of exacerbations, then your lung function is worse than falling off a cliff. It just plummets to the ground, all right? So this is a great slide to kind of talk to your patients about how quitting smoking is a good idea because every cigarette does chew away at that tree and drops your leaves off. And over time, you actually may feel like the next guy who never smoked because you're at least not aging as well. The one thing I don't like about this diagram is that emerging data, you know, we look at this diagram and we think, well, in general, everything's heading in the wrong direction, right? But what we know is with good treatments, adherence to those inhalers, and staying out of the hospital with COPD flare-ups and pneumonia, there's a subset of patients that actually can have an improvement in their spirometry. And this 1970 graph never really learned that. It's only now in the mid-2020s that we're seeing a lot of patients with good therapies at least have improved airflow. So it is possible to have your FEV1 improve, okay? So that's the good news. All right, so I love this study. This study was a European Respiratory Journal study in 2013. It took place across 17 European countries. Study investigators basically called patients with moderate to severe COPD who had been living their daily lives at home, who did not have a COPD flare-up for 3 months prior. And they basically just asked them questions over the phone, and they said, tell me about your symptoms. And what these patients, by and large, were affected by mostly was breathlessness, then phlegm, then cough. Wheezing and chest tightness were present, but not so much. So your cardinal symptoms of COPD often, patients will always complain about being dyspneic and just dyspneic. Some of them may or may not have cough and phlegm production, but a majority are these top 3 cardinal symptoms: breathlessness, phlegm, and cough. This study, when they interviewed these patients, this is the other thing. This was practice changing for me. And this is practice changing for my house staff, those people I was telling you about that all they want to do is keep adding on inhalers on their patients. And I say, no, no, no. Go back and make sure these patients know how to use their inhalers. This study is responsible for the way I teach my students now, okay? What they asked the study subjects was, well, when does your COPD bother you most? The majority of patients, when they reported breathlessness, cough, chest tightness, phlegm, and wheezing, their symptoms are affecting them early morning and morning. So if they don't control their COPD early morning or morning, then the cow's out of the barn and the rest of the day is horrible for them. So how has this been practice changing for me? I will tell my patients, before you wake up and get out of bed, before your toes touch the ground, take 2 puffs of your albuterol rescue. Before you get up, before your toes touch the ground, take a neb treatment. Go shower, come back, take your controller medication, all right? Some of my veterans were ahead of me on this by years. They already do this, okay? But this is practice changing. If you have a patient who's having some bad days and good days, don't add on more therapy. Tell them to use their rescue inhaler more, and tell them to use it first thing in the morning or early morning, okay? And by early morning, some of my guys wake up at 4 or 5 o'clock in the morning, okay? So practice changing. This is also practice changing for me. This is what I tell my patients. We tell our patients that their rescue therapy and COPD is for emergencies. An emergency, they take to be a real emergency, so they never use their albuterol. And so lower the expectations. Tell them as needed or when needed. Make it okay for them to use their albuterol rescue. So a lot of my patients would come in really in distress but have never really tried using their albuterol because they misunderstood my direction. So when I say it now, I say use your controller and then use your emergency or use your as needed as an add-on. It's an add-on. It's meant for you to be used. I'd rather you not be a bump on a log. I want you to push yourself. I want you to vacuum the house. I want you to wash the dishes. I want you to take a walk. And if you have to use more albuterol, that's fine. That's what it's there for. So practice changing for me. What this study also found was that COPD is a very variable disease, and that's normal. Even for patients who are controlled, Monday might be a bad day, Wednesday might be good, Thursday might be really bad, for no specific reason. And what they found was overwhelmingly, patients did not modulate their rescue inhaler use according to good days and bad days. So recognize and reinforce they're going to have good days and bad days for no reason. That's just COPD. It's okay for you to use your albuterol inhaler. So this is the MMRC scale. It's a measure of breathlessness. I don't really use this. I think it's too crude of a measure, and most of my patients are going to rank high anyway. It doesn't tell me much. I use the CAT score. I love the CAT score. The CAT score is a validated questionnaire. How many of you guys use or have heard of the CAT score? Not enough, not enough. So the CAT score is great to establish a baseline. It's great to see if your patients are using their inhalers well. It is predictive of impending COPD flare-up. It is predictive of recovery from a COPD flare-up. And so what it is basically 40 points, 8 questions on a 5-point Likert scale. And patients have to tell you, I never cough, or I cough all the time. They comment on their phlegm production. They comment on their chest tightness. So the top 3 questions are your symptoms, your airway symptoms, okay? And then the next thing here is breathlessness when you walk up a hill or flight of stairs. The next question is being limited with activities. The next questions is whether they're confident leaving the home despite their lung condition. The next question is sleep and whether they sleep soundly. And the next question is having lots of energy. Do any of you guys ask your patients about whether they're okay leaving their house because of their COPD? Does anybody ask that question? Okay, I want you to put a pin on that. Oh, one person back there. Put a pin in that. Why is anxiety or confidence leaving the home so important? Put a pin in that. We will get back to that. Okay? This is important because it gives you the whole holistic picture of your patient and their symptoms of COPD. Energy is a COPD symptom. Sleep is a COPD symptom. Confidence is a COPD symptom, not just the airway symptoms of the top 3 questions. Practice changing. Change your practice. Use a CAT score if you can. Okay, so basically PFTs are the gold standard. What you have here on the left is normal. Patient maximally expires to their peak value. In COPD, their peak value is down. So early COPD, these are the few updates that I'm going to just show you. Number 1 is that even healthy smokers, patients who are smoking, and if they have normal spirometry, we don't say that they're fine. We call them early COPD. We put a little label on them because the science is suggesting that the smoking is kind of causing slow airway remodeling, which you guys know about from the previous talk. Can you code this as anything right now? Is it actionable clinically? No. But something to think about, all right? And the reason I talk about this is because there are patients that smoke and that they have normal lung function, but about a quarter of them actually have abnormal CTs. So this is kind of to help you counsel your patients who are smoking, who don't have COPD, just to help you tell them, well, listen, you know what? We know from the data that you might have early COPD. I just can't see it on spirometry. So this is more a smoking cessation counseling slide for you, okay? Okay, so actual COPD though, forgetting about patients with early theoretical, maybe in the future developing COPD, actual COPD is vastly undiagnosed. We have patients out there living their lives and they've gotten spirometry that's been abnormal, but nobody's doing nothing about it. In Denmark, 78% of patients were undiagnosed even with an abnormal COPD. I wager to think in the US it's probably worse, okay? So that's pretty much my updates and my assessments for emphasis for you for the first section. Think about telling your patients to use their rescue more. COPD is highly variable between Monday through Friday for no reason whatsoever, okay? The timing of their symptoms are early morning. Help them learn and use their inhalers correctly. And for your smokers, tell them that we know smoking is causing early damage. We just can't see it in spirometry, but if we look the right way in a CAT scan, we're seeing early air trapping and gas trapping. All right, so let's go straight to the guidelines now. The guidelines did change, and I'm going to talk you through. How many of you guys, by the way, were here in 2019 in this room? Okay, so, okay, all right. So for a few of you guys, some of the slides are going to be repeat, but hopefully review. So I look at COPD holistically. I think about confidence, I think about energy, I think about fatigue, I think about sleep. So when I think about all of my to-do items for COPD, I kind of put everything on there. I think about what their spirometry, and I risk assess them, and I will talk about how you risk assess them. Do they smoke or not? What is their CAT score? How many exacerbations have they had, 6 months to a year? I write down their PFTs. If I can get a 6-minute walk, I want to see if they desaturate after walking 6 minutes. I have some imaging. I know what their alpha-1 trypsin level is. If it's diminished, then I may need to think about repleting the alpha-1. If I can get an ABG, especially in my severe COPD patients, I'd like to document that. I think about all their comorbidities, their heart failure, their AFib, their hypertension, their cancers, everything. There's mental health stuff. I think about echocardiograms, their heart function, bone densities. I also try to check, at least on my patients with moderate and severe COPD, I like to have immunoglobulin levels checked. You guys can order these. It's probably a special order, but you should be able to do this. Do this on your moderate and severe patients. You'll check IgG total, and then you'll check their subclasses, IgG1, IgG2, IgG3, and IgG4. If the immunoglobulins are low, then these patients may be getting respiratory infections because their immune system is depressed. And you can give them immunoglobulin repletement, and then they will have less lung infection, they will have less COPD flares, and less bad airway remodeling. So IgG is something good that you can get. Total IgG and IgG subclasses. Make sure their vaccinations are done. Their pneumococcal vaccinations, their influenza vaccinations, and their COVID shots and boosters. Okay, I write down the treatment plan, document whether they need oxygen, have they ever done pulmonary rehab, will they do pulmonary rehab, refer to pulmonary rehab. I always document end-of-life goals of care and healthcare proxy issues. Why is all this stuff important? Because COPD is not a bullet to the head. I talk to my patients just like I'm talking to you. COPD is not cancer. There's no therapy that's going to put your COPD in remission. You don't get to walk away from your COPD if you cure your cancer. You get screenings, but you're done with cancer, right? With COPD, it is a slow, torturous decline. Some of my patients with end-stage COPD who I have put on hospice have graduated hospice past 1 year, 2 years. I put one guy on hospice 2 or 3 times, and he is still alive. It's been 6 years. So tell your patients life with COPD can be good. Set reasonable expectations, but make sure that you have this talk with them, okay? Especially your severe COPDers, and you know who they are. Case of Mr. G, 65 years old. He's actively smoking, now half a pack a day, 70 pack years. Has all the cardinal symptoms of cough, sputum production, wheeze. His CAT score is high. What's the threshold? So anything above 12 on the CAT score means they're having more COPD symptoms. Anything below like 12, I consider controlled COPD. So his COPD is uncontrolled. He's short of breath, walking 150 feet. He can't climb stairs. He had a COPD admission 3 months ago. And he's had at least 2 ER visits, several prednisone bursts and antibiotics, doesn't use oxygen. He has heart failure, anxiety, depression, diabetes, hypertension. So his inhalers, he's using albuterol alone and only and 15 others per day. Now remember, this is not asthma. Put the asthma things aside, but he's using albuterol alone and his other meds. His resting oxygen is 94%. When he walked, he dropped down to 88%, and he was symptomatic. He was short of breath. So I fill out that same checklist. So in the italicized, it's basically me kind of writing my SOAP note here and putting in all the data. And then we're going to go through together how we stage him, how we risk assess him, how we do his PFTs, and how we'll develop a treatment plan according to our new guidelines. Is everybody with me and how I'm walking you through this? All right, so I haven't yet documented any pulmonary rehab or family stuff or end-of-life stuff, but that's where we're at. All right, so in 2017, there was a huge change in the way GOLD conceived of how we assess our patients. So it used to be that GOLD said, we have to know somebody's FEV1 because FEV1 impacted patients' risk of illness and their mortality, okay? And so for primary care doctors, you were kind of shackled because you guys couldn't really do much without getting an FEV1, according to the guidelines. But you and I know how hard it is sometimes to get PFTs, okay? Maybe they're not at the site that you work at. Maybe you don't have like reliable in-office spirometry. Maybe you refer them, but it's months before you see the patient back again, or they never show. So see, the spirometry information may be missing from what you have, but the patient's right in front of you, and you want to treat them. So the data also said that, guess what? Spirometry is less important than the patient's own information and their history of exacerbations. And I can tell you that I have 2 patients with the same exact bad numbers on their spirometry. However, the guy that's doing well and is not in the hospital with recurrent pneumonias, and he's using his inhalers and he's not smoking, his outlook is vastly different than the different guy with the same exact bad spirometry numbers, but he's smoking. He has heart failure. He was intubated 3 times, right? So patient-specific factors and a history of admissions and intubations is more important than the FEV1. And it used to be in risk assessing, GOLD made you factor in FEV1. Now they don't. So this was the refined tool. And basically, and they separated it. So if you have the spirometry, then you can stage them. If the FEV1 is above 80 and their ratio is low, they have mild COPD. If their FEV1 is below 30, they have very severe COPD. And in the middle, you've got your goal 2, goal 3 as specified there. So that's how you would factor in your spirometry if and when you have it at the beginning or whenever you get it. But in terms of risk assessing, the 2 things that matter are the 2 things that you can do the first time you see your patient with COPD. You ask them, you look at their CAT score. And if it's below 10, they're here. If it's above 10, they're here, okay? And then on the y-axis here, you ask them, well, how many times have you been having a flare-up? Did any of these flare-ups take you to the hospital? And if it's 0 or 1, they're lower. And if it's at least 1 leading to a hospitalization or at least 2 exacerbations in the year, then they're higher risk. And then it's just a matter of triangulating them. So my guy with a bad FEV1, a very severe gold stage COPD, who's living his life well, he's walking, he's quit smoking, his last flare-up was maybe 2 years ago, and he has low symptoms, that severe gold stage 4 COPD patient may be gold A. And I will treat him differently than a different patient with very severe gold stage COPD, but maybe he's had multiple admissions to the hospital, including the ICU. And when I give him his CAT score, it's 20. And he might be a gold D, right? So you just see how that works differently? And so that's how you risk assess. So for our patient, then Mr. G, his flow volume loop is really severely obstructed. And his FEV1 over FVC is below 70, so you know he has obstructive lung disease. His FEV1 is below 30, so that's gold stage 4, very severe. And then when I risk assess him, he's had admissions to the hospital, and his CAT score was 20. So he's gold stage 4, D risk. So I'll fill that in there. All right. So I filled in that information here and here. And now let's talk about treatment, because this is a pharmacologic conference. All right. So airway inflammation and bronchodilation. Again, this is where that oak tree analogy really helps with the patients. You can use it for asthma. You can use it for COPD. What I tell my patients, because I live in New England and winters here are horrible, I tell them that their airways are like the roads. So to bronchodilate, I'm going to widen the roads. I'm going to give them a bronchodilator. To clear out the snow that's obstructing the road, I'm going to give you an anti-inflammatory. All right? Another analogy, if you so choose. So patients get confused. They use the inflammation stuff for the bronchodilation and vice versa. Just a reminder here, you've got different ways to bronchodilate in COPD. In COPD, you've got your albuterol type drugs, which is your beta-2 agonists. They relax the smooth muscle, okay? You've got anticholinergics like ipratropium and also called Atrovent, and they also relax the smooth muscle of the airway. And then you've got the antimuscarinics, which also prevent smooth muscle contraction, but they do so kind of at the level of the synapse between the neuron and the muscle. Just a review there. All right, so bronchodilators in stable COPD. And this is evidence level A. So short-acting bronchodilators help improve your symptoms. They increase your FEV1, and you can use this as needed or PRN. You can even use these in combination. And generally, GOLD says combination therapy is better. So if you have like a COMBIVENT, which is short-acting muscarinic, ipratropium with short-acting albuterol, you can absolutely do that. Either way, combination may be better than either one alone in improving symptoms, improving your FEV1. Again, do I have my patients on just Atrovent? Just albuterol? Absolutely. That's because I have them on a long-acting muscarinic, and so I don't use a combination rescue. But it depends on how you want to work it and how your formulary is and how your patient is. Long-acting bronchodilators and long-acting muscarinics improve lung function. The LAMAs are it's called, like the main ones would be tiotropium or Spiriva, all right? LAMA, that's a LAMA, it's a muscarinic. So again, because I do this talk after asthma, it's okay if you guys are getting confused a little bit because everything's coming at you and it's not the same. There's similar words and similar letters, but LAMAs are long-acting muscarinics. The most common one is like tiotropium. There's aclidinium and umaclidinium. There's mixtures and all kinds of inhalers. How many of you guys use Spiriva or tiotropium for your COPDers? Great, great. So in COPD, that's first line. In asthma, it was like step 5. It was like an adjunct, right? So in COPD, long-acting muscarinics is your first line. So for you guys seeing your patients who are having poor CAT scores, who are in and out of the hospital, and they're just on albuterol alone, you need to give them a long-acting bronchodilator called a LAMA, like Spiriva. LAMAs are actually better than long-acting bronchodilators in reducing exacerbations, okay? And now this is one major difference between asthma and COPD. This came out in the question. Remember, long-acting bronchodilator use alone, a LABA alone in a LABA alone in asthma, somebody can sue you for doing that because that can cause asthmatic catastrophe. In COPD, using a LABA alone is okay. And in fact, there are inhalers out there that are just long-acting bronchodilators. Just be really sure your patient doesn't have asthma too. And we can talk about that later. So in terms of bronchodilators, again, the long-acting bronchodilators, this is LAMAs. This is the tiotropium or the umaclidiniums or the glycopyrrolates. These reduce hospitalizations. They reduce exacerbations. And again, this is the other major point. I'm going to hone this in so you get sick of me saying it. These single-use, long-acting muscarinics, one inhaler, is better than using ICS LABA, okay? Another big difference between asthma and COPD here. In COPD, the general trend is actually to try to move away from inhaled corticosteroid. GOLD really believes in long-acting muscarinics or long-acting LABA. You can do a LAMA, you can do a LABA, you can do a LAMA-LABA, even for your higher risk, D patients, all right? So those are differences. So Spiriva improves the effectiveness of pulmonary rehab. So patients going into exercise, they need that bronchodilation, because the main pathology here is airflow obstruction. So in terms of inhaled steroids, all right? So inhaled steroids, ICS and LABAs, they're better together in a combination drug like that Advair or like the Symbicort or the Dulera, all right? Rather than giving somebody separately a Flovent and separately a Forido. So one is better than two, so a combination inhaler is better. And there's also this whole discussion in the guidelines about triple therapy. So the triple therapy, all of my patients who are like severe or like moderate COPD or severe COPD, and they're poorly controlled, I have them on ICS, a LAMA, and a LABA. But my formulary, I have to give them 2 inhalers, not just 1. There is something out there, you guys know Trelegy. How many of you guys have, okay, Trelegy. So Trelegy, it's like $1,000 per inhaler. So in the VA, we can't give patients Trelegy. It's just too expensive routinely. We have something called Breztri, which is cheaper, okay? The GO guidelines, again, basically they recommend triple inhaler therapy, 3-in-1, because one single inhaler is better. Patients tend to not do things correctly. So in terms of, this is an update, meaning mostly emphasizing that GOLD really wants you to reserve the use of inhaled corticosteroids in patients who really, really, really need it. So those that have had a COPD exacerbations, those that have had at least 2 COPD exacerbations per year, those that have eosinophils in their sputum, and those that have some asthma, okay? So you can also, the same way you kind of phenotype eosinophils and asthma, you can phenotype COPD as well. So ICS really should be for your patients with COPD asthma overlap or patients who are poorly controlled with their COPD and have had to go to the hospital and do it, okay? So other adjunctive therapies would be macrolides like azithromycin. Azithromycin is an antibiotic, but it also has an anti-inflammatory effect. So usually for this, what I do for these patients is I give them like a lower dose, 250 milligrams, Monday, Wednesday, Friday, thrice weekly. And that's a great adjunctive agent for patients who are already on triple inhaler therapy, who already have a nebulizer, who already are doing things correctly. Add on that adjunctive. Just make sure their QTC isn't prolonged, okay? And make sure you know their hearing is okay. Because too much azithromycin can cause hearing impairment, but the data is actually when you use a higher dose of like 500 or more. So that's why if you do 250 3 times a day, you're fine. I don't send my patients to hearing tests. And what we know is that azithromycin decreases their risk of flaring up by about 30%. Another adjunctive therapy that you probably cannot write for yourself, is anybody writing for Dalaresp or Roflumilast? Oh, okay, you are, all right. Are you guys working in pulmonary clinics? Yeah. So this is mostly a pulmonary clinic site, and so refer to your pulmonary colleagues, your NPs and MDs and PAs working in pulmonary clinic. This is basically a phosphodiesterase inhibitor, specific indications for GOLD 3 and GOLD 4 COPD. Patients who have chronic bronchitis and recurrent exacerbations, you will end up starting them off on a dose of Dalaresp. A lower dose for 4 weeks, as long as they can tolerate, you'll increase it to a maximum dose, okay? All right, so this is what I did for my patients with COPD. I sort of have in my mind the constellation of inhalers regimens out there, and there are a lot, and it's confusing. And so what I recommended to your group 3 or 4 years ago was, look at your formulary, make a list of what you have that's first line, second line, divide it up into the different classes, and then have like a standard approach according to the guidelines. So here I've divided it up into your short-acting bronchodilators, your long-acting bronchodilators, your inhaled corticosteroids alone. This is your triple therapy, your Cadillac, Trelegy, or your Tesla. And then this is your Breztri, okay? This is your combination ICS LABAs that's out there on the market. These are your LAMA LABAs, all right? This is your, and these factor in the guidelines, and I love LAMA LABAs, they're awesome. And then there's your long-acting bronchodilators. There's the Elliptas, the Tudorzas, Spirivas, Sebree may be off the market, and then there's combination. And this slide is updated as of like last month. Okay, so again, similar themes from asthma. I'm not going to belabor this. Correct inhaler use is not common. It's pretty much the same slide and review. I hope you remember this in your dreams. All right. Spacers improve drug delivery. So give them a spacer. This is a smaller one that we have at the VA. But when you put the inhaler at the back of the spacer and they breathe through the spacer, the heavy particles like settle into the spacer, and then the lighter particles get inspired all the way down into the lungs. You'll have better drug delivery. And with your inhaled corticosteroid, if it fits in a spacer, it's great because they get less oral thrush. So I've already talked with you about my like peanut butter in the sandwich and fluff on top analogy. It works with COPD better than asthma now. I tell them your controller is your everyday. You must use it every day. And then because COPD is a variable disease, you must use your rescue when you need it. Okay, now let's talk about the guidelines. So these guidelines are different. And for those of you that were here in 2019 in this room, these are newer slides for you because the guidelines did change from before COVID times, all right? So you already know, I've already explained to you what the x-axis here is. This is basically CAT score less than 10 means good COPD control, and CAT score above 20 means not good COPD control, needs action. CAT score above 10. And then on the y-axis, you basically have their history of exacerbating. In the y-axis, above is more than two or more outpatient, or at least one leading to admission. And this is 0 or 1 moderate, not leading to admission. So if you're basically not having a lot of symptoms, not going into the hospital at all, or maybe just once in the last year, you could get away with just having a bronchodilator. If you escalate, you're going to need a long-acting bronchodilator. So this is probably a short-acting that you use when needed. This is a long-acting. If you have higher admission history and lower symptoms, you're going to use the LAMA, which is like that tiotropium or one on that list I showed you. And then group D, and this is the major change because GOLD 3 years ago before COVID actually said it was okay to use ICS LABAs. It was okay to introduce patients to inhaled steroid here. And so the major change is they really don't want us to use inhaled steroids unless we absolutely have to. So if they're still going to the hospital a lot, just give them a long-acting muscarinic, educate them about how to use it, educate them about their nebulizer and their short-acting as well, work on all of their other stuff, their sleep, their energy, their mental health, their exercise. Tell them to bronchodilate first thing in the morning. But modify all the basic stuff before you add on another therapy. GOLD really wants us to save LAMA-LABAs for group D and save ICS, inhaled steroids, and long-actings for group D, all right? All right, this is the other update slide. And right now, if you guys are zoning out a little bit, I understand. It's been a long morning. And there's a lot of acronyms, which I find really obnoxious, especially if you're not a pulmonologist. LAMAs, LABAs, ICSs, SAMAs, SABAs, all sorts, all right? So I'm going to go over this. In theory, we'll go over some cases so it's more crystal clear. If it's clear as mud right now, I understand, I empathize, I commiserate. All right, so this is a new slide. What they want you to do in terms of following up and escalating treatment is they want you to go off the patient's symptoms. So this is new. They want you to see, is the patient's predominant symptom of poor COPD control really their dyspnea, or is it that they're having frequent exacerbations? Either way, you have to escalate their therapy. If it's dyspnea, then they really want you to move from just using either the long-acting alone or the long-acting muscarinic alone. They want you to use the LAMA-LABA alone, the combination LAMA-LABA. In fact, they go so far as saying if you have them on an ICS steroid and they haven't had a lot of exacerbations, they're just complaining of shortness of breath to you, get them off of the ICS LABA because the inhaled corticosteroid gives them pneumonia, and so put them on a combination. Okay, LAMA-LABA. And then they say, if this doesn't work, then maybe think about spacers, inhaler device, add adjuncts like azithromycin or Dalaresp, and investigate other causes. If your patients are basically coming to you with having a lot of exacerbations, and they're only on the single inhaler, either a LABA or a LAMA, they're saying put them on both. Okay? So put them on a combination. If If they're doing okay on follow-up, again, they want you to really taper down. And if they're not doing well, they really emphasize this triple inhaler therapy. Now, Trelegy, all my patients come to me and they see these awesome commercials, and you've got these patients golfing or doing like, weird things on the pharmaceutical commercials, and then they'll say, Trelegy, ask your doctor about Trelegy. Everybody wants Trelegy in my clinic, but they come to the VA for their care. They don't have private health insurance. I told you Trelegy costs $1,000. So I can't give them Trelegy, but I basically give them the triple inhaler therapy. I just give them the LAMA separately, and then I'll give them the ICS LABA separately. So they'll carry 2 controllers and 1 inhaler. And as long as I teach them how to do it, I'm pretty okay with them doing that. There are some patients that insist they want the triple inhaler, and in that situation, I'll have to do other hoops and jump through, and I'll try to get them the single inhaler therapy. So if they have just that triple in one, the 3-in-1, then they'll carry the 3-in-1 as the controller, and they'll carry the albuterol short-acting as the rescue. So the Trelegy triple inhaler is in their bedroom, and the albuterol is in their pocket. Okay? My patients are mostly men. They don't carry purses, so they don't have a spacer, which is not great. Okay. And then if things don't work out, then, and if my patients are having a lot of exacerbations, I will definitely put them on azithromycin, and I will consider Daliresp as well. That's like 4th line and 5th line when you're going deep into your toolbox. All right, so let's go back to Mr. G to kind of get things a little clearer for you guys, all right? So we said Mr. G was gold stage 4 severe, right? His FEV1 was 26. We know he doesn't have any features of asthma, but his CAT score is high, and I think he was in the ICU, and he had several COPD flare-ups. So for him, he fits in this gold D box. So for him, he could get a Spiriva, or he could get a LAMA, also tiotropium, also Spiriva. He could get a LAMA-LABA combination bronchodilator, which is like the one that I have in my formulary is tiotropium, olodaterol, which is called Stiolto, all right? Or you could give them the ICS LABA. And to be completely honest, and what happens in the real ground is basically when my patients are like group C-ish, and definitely group D, I am using an ICS LABA. My patients need a steroid inhaler. Gold really just wants you to be thoughtful about giving them to these patients, okay? So we'd put Mr. G on group D therapy. And then on follow-up, Mr. G still complains of shortness of breath. So at this point, like I said, I would consider re-educating him about spacer use. I would add on my adjunctive therapies like azithromycin or Daliresp. If he exacerbates, I'm definitely adding him on these medications. Okay? So let's just review some basic clinical pearls. Key points about stable COPD. You really want to prioritize long-acting bronchodilators. LAMA alone or LABA alone. Combination is better than either single. And then you want to consider steroids if they have a history of high eosinophils or if they're group D, okay? Do not use steroids, inhaled steroids alone for monotherapy in COPD, okay? Monotherapy ICS is asthma, not COPD, all right? So let's go now to this case 1, and we'll do this together. A 55-year-old man in the emergency room for 1-week history of new cough, sputum chest tightness. He smokes 25 years, half a pack a day, trying to quit. He's physically active. He does get short of breath. Never been to the ED, never hospitalized. This is his first ED visit. He was nebulized with Combivent, discharged home with prednisone and antibiotics. He comes to you. He feels better now. His CAT is like 5. That's awesome. The prednisone helped. He's not using any inhalers. And you did everything. You dotted your T's and crossed your I's. And full H&P, everything looks great. It checks out. So let's do it. What are we going to do now? He's okay now. Discuss smoking cessation. This sounds familiar. Let's screen for COPD. B, C is initiate a short-acting bronchodilator as needed. D, initiate a long-acting bronchodilator and do several things above. So in terms of this, I will walk you through this. So the answer is pretty much do several things above, okay? So if the patient isn't having symptoms, don't bother screening them, but really do a good investigation for screening. So screen for COPD in patients who complain of symptoms. If they just smoke and they have no symptoms, then I would refrain from screening them. I think that's just a healthcare cost issue. And going back to our case, we don't, of this emergency room patient that we're looking at, we don't know what his spirometry is. That's to be decided. But his CAT score was 5. He recovered, and he only had that one and only emergency room visit. So he's gold A, and he's gold A because he's kind of less risk. So your options then, with my cheat sheet that I developed for myself, is bronchodilators in stable COPD. You could give him a short-acting LAMA. You could give him a SAMA, which is a short-acting antimuscarinic. You could give him a SABA like albuterol, short-acting bronchodilator, beta agonist. Or you could do a combination, which is a Combivat. Okay, that's a Respimat, which is a different kind of device, but it works really well. So again, just a reminder that combination short-acting is fine. It's probably better than either or. But all of these are great options for you. You've got many options for him. So basically, the answer is E. Do all of several things above. I would discuss smoking cessation. Hey, buddy, you're smoking. Not good for you. There's a risk of, early COPD. So stop smoking. He was symptomatic. I would screen him for his COPD. Initiate a short-acting bronchodilator, PRN, okay? I would not, at this point, commit him to a long-acting bronchodilator. I would just start off with a short-acting, and that would be fine. For COPD, short-acting alone is fine. So do everything and follow up, okay? Does that make sense? Good. The next case, so 69-year-old man, he's an ex-smoker, increased cough, shortness of breath, and phlegm, going on 6 months now. No fevers, chills, hemoptysis, or weight loss. He does get short of breath after climbing several flights of stairs, and he's been using an albuterol 6 times a day. His lab work is normal, and a chest x-ray I'll show you. He had spirometry that showed airflow obstruction. And this one basically showed an FEV1 of 54, so he's gold stage 2. His chest x-ray looks like this. His CAT score is 16. And you can kind of look at the breakdown on your own time and see which symptoms are more. But his CAT score is bad. It's above 10. So let's poll our plan here. So remember, this guy is only on short-acting albuterol 6 times a day. We know he has COPD. We've known for 6 months. We haven't done anything about it. And he's sick. So continue present management? No. Repeat PFTs and refer to pulmonary? Not necessary. Why put him through that? You already know he has COPD. And don't refer to me. You guys can take care of him. Start a maintenance inhaler, ICS LABA. Who wants to start a maintenance inhaler in him, ICS LABA? Good. I've done my job. Good. No, do not do that. He's not an asthmatic. He's a COPDer. We want to really reserve the ICS LABA only if he needs it. Oops, sorry. So start a maintenance inhaler, long-acting bronchodilator, or LAMA. Good. I hear mutterings of yes. And then start a maintenance inhaler, ICS alone. No, that's most right. Exactly, asthma. So I think I said that we should do D, but we'll see if we're correct. So LAMAs, all right? This is a picture of Spiriva. How many people recognize this guy right here, the HandiHaler? Can you raise your hand? Yeah, that is the most annoying creation in mankind, right? You get a box of pills. Each pill is individually wrapped. You have to struggle to open that damn pill. Then you have to open up this funny-looking egg-shaped thing. Then you put the thing in there. Then you have to puncture it. Then you don't even know if you're getting anything. nonsense, 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 nonsense. How many people have this, have access to this kind of inhaler? Okay, perfect. So this is a Respimat. This is awesome. You get a box, the cartridge is separate, and then the plastic part is there. You put the cartridge in, you slam it on the table, and then the cartridge is loaded in. Then when you open the inhaler, what you do is you rotate it once, it clicks in, you hear the click, and then they open the little cap, they hold the inhaler to their mouth, they press the button, and the nice, beautiful, thin, clear mist comes through, and it goes straight down. So much, much easier than this nonsense egg-shaped thing. And this Respimat technology, not only can you get it for a long-acting LAMA, you can get a Combivent Respimat, the Saba. You can get a LAMA LABA in this Respimat. So you can get Stiolto, at least on my formulary. So if I change somebody, if I escalate their regimen, it's easy for me. I'm like, you don't have to do anything. I'm just giving you a different inhaler with a different color cap, but I know it's got more drug in it. So LAMAs, the Uplift trial basically said that Spiriva or tiotropium improves rate of exacerbation, improves quality of life, okay? And it actually helps prevent the decline of your FEV1. And it's very, very safe, over 10 years of data on that. Inhaled steroids cause pneumonias, they cause cataracts, they cause fractures, they cause thrush. Try to avoid if you can. Lots of side effects. Okay, so for this patient that I was talking about, he doesn't have asthma. Don't give him an ICS alone. All right, combination LAMA-LABA is probably not an option. He doesn't need to escalate. Side effects with the ICS LABA, you can actually give him a long-acting bronchodilator alone. Okay, you can actually give him a LAMA alone. Okay, so if you don't have Spiriva, now in my hospital, I don't actually have access to the Ellipta line of things, but if you do, you might have access to Seebri or to Dorza or something. But the bottom line is you have options for either a long-acting alone or a muscarinic alone or a long-acting bronchodilator alone. And I personally would go with the LAMA. All right, so this is another case. Gold state, and then we'll move on, I promise. So gold state COPD 2, this is the same case, gold 2. So this patient has more symptoms, and he's sort of risk B, which is why we gave him either the long-acting bronchodilator, beta agonist, or the antimuscarinic. So I emphasized this with your asthma lecture last time. I said giving a patient a long-acting bronchodilator alone will cost you a lawsuit. Don't do that in asthma, okay? It's totally not a good idea, but in 2017, it's okay to do that with ICS. So just reassuring you that LABAs are safe in combination, okay? In asthma, long-acting bronchodilators are safe, okay? So the TORCH trial basically said it's okay for you to do in your COPD patients. Just make sure that they don't have asthma. There was a minor risk of some cardiovascular events, but that was really related to the fact that the patients had pre-existing cardiac disease. It wasn't the inhaler itself, all right? So just a reminder that long-acting bronchodilators, either one, LABAs or LAMAs are okay. Combination is always better. So for him, we said basically option D was correct. Start a maintenance inhaler, either a LAMA or a LABA. I highlighted my preference. So let's switch away from kind of basic evaluation of COPD and just a brief run through of COPD exasperations, as my patient would call it, not exacerbations. You might have a normal period and then you have one exacerbation and you're fine again. You might have normal period, you have an exacerbation, you never get well, and then you need additional therapy. Or you might have a trajectory where you just have multiple exacerbations close together in time. Okay. This is actually a study for you guys, and I am going to go through this in detail. I was very excited when I presented this 3 years ago, and it's still relevant because it's for primary care. This is basically what happens to COPD patients in a general in a general primary care clinic. So, and the question they asked is, what is the effect and severity of COPD exacerbations at baseline, and what is the risk and death of future exacerbations in a primary care population? So think of all of the COPD patients you guys have seen in your career in your clinics and clump them all together. And this trial will be applicable to your experience. So about 100,000 patients were followed up to at baseline, which is the first year of their follow-up, and up to a max of 10 years. And then they basically used information from the database in the UK, and they linked it with hospitalizations and death. So this study was possible because the UK has the National Health Service, so they have everything in the computer, and they have outpatient data, deaths, and hospitalization all linked in one EMR. Imagine that. All right. Okay, so in their cohort, this average primary care cohort, average was 68 years old. Over 50% of them smoked. The majority of them are kind of moderate GOLD 2 patients, a smaller subset of severe and very severe patients. And look at this. Most of the patients never really have COPD flare-ups. So most of the patients that you guys are actually following are kind of relatively stable COPDers, all right? About 20% have one COPD flare-up that's treated out of the hospital. And then 10% have about 2 per year, 13% have 3 per year. So this really helps, you know, this is not my perspective on COPD. I see a different subset. So I just wanted to highlight this. Okay. So it's interesting, when they actually looked at baseline and during the first year, and then they looked at follow-up, and I think that the median follow-up was over 5 years. About a quarter of those patients never ever exacerbated in primary care. They were actually managing their disease, and they never had an exacerbation. Some of these patients had their first exacerbation during this study, okay? So that's about 38%. About 60% had COPD. Now, this is the thing, this is the money shot. This is what I want to actually emphasize to you guys. Just when I talk about like airway remodeling and injury remodels the airways and causes worse disease, well, I'm going to talk you through this graph because what this is showing you is there's a dose-response relationship, because one exacerbation carries a risk of a future flare-up, carries a risk of a future admission, and carries a risk of death. So compared to reference, one exacerbation is a 1.7 times increased risk of future COPD outpatient flare-up. It causes a 1.2 times risk of getting admitted, and the risk of death probably no difference, it's just one. But let's say your patient has 3 exacerbations. Their risk of a flare-up is now almost 3 times. Their risk of an inpatient flare is 1.89, and their risk of death is now 1.25, okay? So if your patient has one severe exacerbation, all right, this bottom row, their risk of getting another COPD flare-up is more than 3 times higher. Their risk of having another admission is 3.6 times higher. Their risk of death is 1.8. So with every one exacerbation, your risk of having a flare-up, risk of getting admitted, risk of dying is more. So in practice, what does all this mean? I tell my patients, if you had a COPD flare-up, then I worry about you for the next like 2 to 3 months. I worry that your risk of having another flare-up is high, and I'm going to watch you, all right? So I'm going to skip the specifics of Mrs. C for time, but I'm just going to tell you that I'm just going to point out that women are a different breed for many reasons. Women have undiagnosed COPD more than men. We're treated more suboptimally. We present with different symptoms. We're younger, we smoke less, we have issues of socioeconomic status, a lot of anxiety, depression. We are more than likely to smoke more than our male counterparts, and a lot of occupational. So you can look in your slides for that case, but the case was intended to emphasize the fact that it's a woman instead. But I'm going to move ahead so I can answer your questions. The causes of exacerbations, 80% of the time, is infections. The impact of exacerbations, we know, is healthcare quality costs go up, hospitalizations, economic costs, lung remodeling costs, quality of life costs, accelerated lung function decline, higher mortality with COPD exacerbations. So this is the laundry list of exacerbations. There's like 15 or whatever. But the main big one I want to show you is that exacerbations beget exacerbations beget exacerbations. You will have a frequent exacerbator because you were not able to break that cycle. So the highest risk of exacerbation is a previous exacerbation. Exacerbations cause exacerbations. Okay, I'm going to skip Mrs. C and move ahead. So management of exacerbations, I'm not going to belabor this. I think most of us have known bronchodilators. This is your duonebs, nebulizers, albuterol nebulizers. You'll need your prednisone and antibiotics. Duration of steroids, this is really important. This is also very, very important. We used to put people, like by and large, on these tapers, 60 for a few days, 40 for a few days, 30 for a few days, 20 for a few days, 10 for a few days, and God knows what. We don't really need to do that. There's only a few small percentage of patients where you need to do that. Most of the time, I would say like 90% of the time, should be practice changing for you. You can actually do a burst. You can do a 5-day burst, 40 milligrams times 5 days, and that's it. If they exacerbate again, give them another 40 or 5 days. Try to refrain from the burst. Because remember, in your primary care perspective, most of your patients are having 1, maybe 2 outpatient flare-ups, okay? In your entire cohort, 100,000 patients I presented to you. So really, avoid the prednisone tapers. And then COVID. This is a very beautiful looking, sexy slide about what happens to patients with COVID in general. But I will synthesize it by saying I do nothing different. Just like in asthma with COVID, I'm telling my patients, keep taking the ones that are at home recovering. Right now, I'm following all the NIH guidelines for COVID. If they need, the COPD patients are older with more comorbidities, so maybe they might actually need that Regeneron infusion, right? The antibody infusion. If they need, Paxlovid, obviously yes. But then for the COPD side of things, I'm not reflexively giving them a prednisone burst. I'm actually telling them, take your Paxlovid, drink your hot teas, go to sleep, take your inhalers, take your nebulizers, and call me if things get worse. So not changing anything. If they're higher risk, if I'm more concerned about it, sure, give them 5 days of a prednisone burst. But you know what? And that would be fine in the outpatient setting. If they come admitted to the hospital, they're going to be on dexamethasone anyway for COVID, right? That's your hospital treatment for COVID. So that kills 2 birds with 1 stone. It's going to treat the COVID. It's going to help with their COPD. So for your outpatients at home, living with their spouses or their family members, whatever, just counsel the same thing you've been counseling them, and you can tell them to call you if they have anything worse from a COPD perspective. And again, I'm just going to highlight, continue usual COPD maintenance therapy. And this is a slide from the Blue Journal in Pulmonary. So comprehensive plan. This is the thing. Now, remember back in the beginning of the talk, I asked why, does anybody ask about confidence leaving home? Does anybody ask about confidence leaving home? You don't. 1 person does. So why do we think about confidence leaving home? It's a marker for anxiety level, right? So this is an audience participation question. COPD is a lung disease. True or false? Who says true, COPD is a lung disease? True. Okay. Who says COPD is not a lung disease? Ah, no brave souls out there. So COPD is not a lung disease. This is me, the pulmonary doctor, telling you COPD is not a lung disease. COPD is a total body disease because I ask you about your sleep, I ask you about your energy level, I ask you about your confidence leaving home, and I will tell you why, okay? Comorbidities and risk of mortality in patients with COPD. This is from the Bode Collaborative Group, published 2012. So 10-year anniversary of this paper. I love this paper. This is practice changing. I have a copy of the picture I'm going to show you next on my wall. All right. These study coordinators, what they did was they looked at a sample of a cohort of COPD patients, and they said, what other diseases do you guys have, patients, men and women? And then they said, which one of these diseases that travels with COPD negatively influences survival? All right? And this is why I love it. This is the COPD galaxy, okay? This is like Star Wars in pulmonary medicine, all right? What you have here is the statistically significant border of the galaxy, all right? Color-coded by the type of comorbidities. In this cohort, they found 80 different disease states traveling with COPD. Red is cardiovascular, green is pulmonary, blue is like a mishmash of like diabetes, BPH, renal failure, et cetera, breast cancer, anxiety, et cetera. All right. So a lot of the patients had hyperlipidemia, but so the size of the planet is how many patients have that disease. But it is not in the center of significance. It's not really in the galaxy, it's in the universe, right? So hypertension travels with your patients, but it does not affect mortality, doesn't affect survival. That's hyperlipidemia. Hypertension, also prevalent, but it crosses the line of significance. So yes, it's present, but no, it doesn't affect survival. They only found 12 specific disease states that they thought were statistically significant. Of the 12 specific disease states, which one is the closest to the primary outcome, the center star of death? Which one? Anxiety. Say it with me now, loud and clear. Anxiety. Anxiety, 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 anxiety. The center star of death for a COPD patient is anxiety. Okay. This is association, so I'm supposed to say association doesn't include causality. There's no mechanism I can tell you, no molecule, no absolute eosinophil count that's going to draw a line here. But this is what I think happens. My patients with COPD who can't walk 150 feet, they're running out of space to breathe. They're air trapping, right? And then when they get anxious, they're breathing fast. So imagine yourselves, take a deep breath in, but don't blow out. Now take another breath on top of that, and don't blow out. Take another breath on top of that. So when you're anxious, you're trying to take 4, 5, 6, 7 breaths on top of breaths on top of breaths. These patients will exacerbate. They'll have a very, very bad day very, very quickly. And they end up in the hospital, and they end up on cycles and cycles of COPD exasperation therapies. Prednisones, antibiotics, bronchodilators. They get so many bronchodilators, they come to your clinic and they're shaking like a leaf. They're jittery, okay? They don't need all that stuff. Anxiety, anxiety, anxiety. What you need to do is if they're in that stage, you need to figure out how you can calm them down. To calm them down, don't use Ativan or benzodiazepines. That's contraindicated. I know you want to do that. Don't do Ativan. They have breathlessness, right? They have that breathlessness. You might actually give them a low-dose morphine, low-dose, short-acting. You can give them a liquid morphine. You could give them a small, like oxycodone, okay? Now, this subset of patients, what I'm talking about is your gold stage 4s, okay? But in your moderate, lesser stage COPDs, use Tai Chi, use mindfulness, use exercise, use holistic ways of talking to them. Educate them that anxiety and mental health is the foundation for their control. This is very practice changing. And so that's my theory is that, air trapping makes things worse. When you air trap and you're breathing on top of breathing on top of breathing, you're running out of air, and then you worsen your VQ mismatch, your oxygen level drops, and you go to the hospital and you go into that cycle, which doesn't do you any good. Instead, what you needed was some deep breathing, slow, deep breaths to reduce the air trapping, improve the VQ mismatch. So this is a practice-changing slide. This is a slide that will stand the test of time because it's the COPD comorbidome galaxy of death, all right? All right, smoking cessation, I don't have to belabor this, it's important. The benefits of cessation, I think I mentioned this, is that up to 20% of patients, up to 20% of your smokers who don't want to quit smoking, who may not have COPD on spirometry, you can tell them, listen, you have a 20% chance of actually, if you have mild COPD, your COPD function can actually improve. We can reverse the clock a little bit. Back in 1970, they did not. This chart is not exactly very, very accurate, even though it's classic, okay? So there are physiologic respiratory airway measurement benefits of quitting smoking, and that means regaining some FEV1 function. So pulmonary rehab is important, education is important, self-management is important, vaccinations are important. Oxygen use, I'll just summarize by saying that the Medicare criteria is still active, relevant, that if the patient desaturates below 88% or has a PO2 less than 55 with cor pulmonale, you definitely want to give them oxygen. The main issue here is this LOT trial. I'm going to skip over that, which basically says, you know, back in the day, about 5 or 6 years ago, if my patient desaturated with walking, if they desaturated below 88%, I would give them exertional oxygen. Now, I don't have to do that, and if the patient doesn't want oxygen when they're walking around, that's fine, I don't pressure them. The only true indication for your COPD patients to need oxygen is if they desaturate below 88% at rest, then we know oxygen prolongs survival. Exertional oxygen alone is not necessary or indicated to prolong survival. I still prescribe oxygen for exertion if my patients want it, and there is some symptomatic benefit. But in terms of the primary hard outcome of improving survival, oxygen is indicated for only resting hypoxemia below 88%. And I'm going to stop there. Same thing. There's some additional resources about inhalers and how to use them, and let's get to questions.
Okay, we've got quite a few. Hopefully we'll get to them all. Is there a remote possibility that COPD advances more quickly after each exacerbation due to SABA overuse?
Yeah, because you're sort of thinking about the asthma lecture. I don't think so. I think that what I tell patients is that lung inflammation and exacerbations beget more exacerbations. So frequent SABA use, in my experience, the patients generally tend to have more jittery side effects, and without the use of inhaled corticosteroids or some long-acting control, they're just never getting under control. There's no data that I know of right now that SABA use, frequent SABA use alone remodels airways in the same way as in asthma.
Thank you. What scale should we use in patients with cognitive impairments or those that cannot answer the questions on the CAT?
Good question. A caregiver, or oftentimes I use my patients' wives. Most of my veterans are male, and so I'll use a caregiver or somebody else. If you cannot elicit that information, then use your subjective judgment to kind of assess what's bothering you the most. The CAT works best if the patient is filling it out themselves, but I've had patients that don't have their reading glasses, or during COVID, we were on the phone, so I would just kind of generally ask them those questions and fill it out myself. So I ask you to use your own judgment.
Okay. You mentioned COPD patients using albuterol first thing in the morning. Are we not as concerned with COPD patients and albuterol overuse?
Yeah, so the data, at least the reason I say that is that a lot of my patients wake up and they say that their morning phlegm, morning cough is really bad. And if they're having more bad days than good, I'm telling them that it's okay for them to use their albuterol first. I think I would consider albuterol overuse if like every single day for a consistent period of time, whether it's 1 or 2 weeks, they're using their albuterol, every single day 4 to 6 times. But my recommendation for them to use it first thing in the morning is so that they open up their airway, all that phlegm that's trapped in there from the night, they can cough up and get out. And then when they take their controller medication, more of it sort of goes in. And I think this is a strategy my patients actually taught me, and then I saw it years later in that trial that I presented.
Okay, we have a couple of questions about immunoglobulin therapy, the indications and treatments for them.
Yeah, so immunoglobulin therapy, really the indications is if they're having recurrent, if your patient comes to you with pneumonia and you can't explain why, if a patient has a stroke or is an alcoholic and they blacked out and then they aspirated, or if they have a stroke and they have swallowing difficulty and they have aspiration pneumonia, that's probably, separately related. But you can still check IgG levels on them, but the indications for treatment really are if you check the levels and they're low, and if they have recurrent infections, then I would go ahead and consult whoever you need to consult in your system to get them IVIG therapy. It's usually IVIG therapy, I think it's usually monthly, it might be biweekly, but the allergy doctors would decide that.
Okay. Any indication for using IgG as a marker for treatment?
So yeah, if total IgE is low, and then if you have your subclasses are low. But yes, if total IgG is low, then that would be an indication to consider IVIG therapy.
Okay. Does LAMA or LABA help with idiopathic pulmonary fibrosis?
Great, idiopathic pulmonary fibrosis. So usually patients with idiopathic pulmonary fibrosis, if they just have idiopathic pulmonary fibrosis, they will have a restrictive lung disease, which is a totally different bucket than airflow obstruction. So I don't put patients on long-acting, but I might give them a short-acting albuterol because they can take that, and if they feel any benefit from it, that would be fine. Keep in mind that pulmonary fibrosis is a totally different disease process, and sometimes from diagnosis to death, if it's like a serious case of fibrosis that's developing, we're talking 4 or 5 years. So once I've diagnosed it and I have them on pulmonary fibrosis therapy and I have them on oxygen, I really am giving them, my heart is, I'm giving them whatever I can give them, and a little bit of albuterol is not going to hurt. It's cheap and relatively risk-free.
Okay. Can we diagnose someone with COPD with symptoms alone without spirometry?
You can have a clinical presumption, but in terms of the gold standard for diagnosis, you do need a spirometry.
Okay. Initially, with COVID-19, we were told to avoid steroids.
Yep.
Any contraindications in using them now?
No, I mean, so we had this discussion offline. So early on, March 2020, we had no idea what the heck we were doing with COVID. And so I remember when I did the virtual COVID talk for NPACE, somebody was asking me about budesonide steroids and was that okay for COPD? And this was, I gave the virtual conference October 2020, and there was a clinical trial about Symbicort, so I couldn't answer that question. But now it's June of 2022, and we know that steroids are okay. So if you're in the home, whether it's asthma or COPD, continue your usual therapy. If you're in the hospital, you're going to be prescribed dexamethasone, and that is a treatment for COVID inpatient.
Okay, if a patient is on a LAMA and ICS and is stable, would you then suggest taking them off of the ICS and then starting a LABA?
Yes, absolutely, absolutely. So if a patient is on a LAMA and ICS, usually you don't want a patient on. Usually you would typically have like the patient on an ICS and LABA, and so you can step down and move the ICS LABA away, or you can put them on a LAMA LABA and just get the ICS component out. That would be actually favored by GOLD.
Okay, and someone has a question about the powder formulations, but I think you spoke about the Spiriva and the
Yeah, powdered formulations is just very hard. Some powdered formulations actually make some of my COPD patients cough more. That's mostly because they're not using a spacer, or it's because the inhaler doohickey itself can't be inserted into a spacer, and then that dry powder, the other thing is, the dry powder might settle on their throat and tickle the back of their throat and they'll cough. Or what also happens is that the dry powder, a lot of COPD patients, for example, with Wixella. How many patients here know Wixella? Yeah. So Wixella is the cheap version of Advair, right? It's the same exact drug. Wixella is the generic. It's just not in a very pretty formulation, purple discus. Advair is horizontal. Wixella is vertical. And then the main thing with Wixella, this discus, is when you take the breath in, you have to generate a flow rate that's pretty fast. So to suck up that dry powder. And many patients with COPD may not be able to do that. So they don't have enough of that flow with that initial breath. And then they may not be able to do the inspiratory breath hold and hold it apparently 6 to 10 seconds. 6 to 10 seconds is a long time for a COPD patient. So that makes dry powders challenging for some people.
Thank you so much. We have 2 additional questions, and we can talk to her offline because we have to end right now.
Sounds
Dr. Saida,
good.
thank you so much for your presentation.